Well, thank you. My name is Nick von Bergen. I'm a pediatric cardiac electrophysiologist up here in Madison, Wisconsin at the University of Wisconsin. And I get to discuss with you the process of new technology assessment. It looks fancy, but is it useful? I do have a disclosure. My disclosure is that I invented the Atriamp, and I'm a co-founder of Trinity Medical, a device that we'll actually be discussing a little bit later in the technology parade. So technology, and new technology in particular, comes in lots of shapes and sizes. I put some examples up here. This is a stereotaxis, which requires readjustment of the whole cath lab, bringing in these huge magnets for a whole ablation system. We have things like the EnSite system here, which is of course much smaller and much less expensive than the stereotaxis. And then we can look at things like the disposable stuff, the HD grid and or an irrigated tip catheter, or perhaps a Tyrex pouch when the antibiotic associated pouches. All different technologies that have been adopted by many of us at our centers, and things we need to think about as we evaluate and we assess their benefit and or costs and or risks. We'll also discuss a few things today, things like the Atriamp, continuous EKG monitoring, the EP command, which allows mixed reality monitoring of the EP three-dimensional mapping. We're going to look at some tiny pacemakers, virtual heart modeling, home monitoring, such as the Cardia app, and also non-invasive blood pressure monitoring. And I bring these up now because I want you to think about the process of tech assessment as you think about the potential for new technology that we'll show later. So can we have it all? This is actually a statement from one of the government agencies that I thought was fairly appropriate. It said, just like every other healthcare system in the world, public or private, has to set priorities and make choices. The issue is not whether there are choices to be made, but how those choices are made. This seemed to me like something my hospital would tell me, or perhaps the US government, but this was UK Parliamentary Health Committee who stated that. And we have to realize that not all clinically effective health technologies are adopted. So this is very much a weight for the scales. What is effective enough that allows us to want to adopt it into our everyday practice? So there's a different number of drivers of new technology. New technology can be driven by the providers, it can be driven by the hospitals themselves, and then as things mature a little bit, oftentimes government and or public health can actually help the adoption of technology. Industry always has a role, and insurance, of course, has a role with payment, which can then also help drive or kind of stifle the ability to integrate technology into the care of our patients. As we think about a kind of progress of technology adoption, we really move through research and development to experimental into more common use. And at each of these stages, the different players have a different role. Initially, we oftentimes have industry in collaboration with providers trying to decide how can we best address these problems as we move technology forward. Once we start getting into the hospitals themselves, it starts to shift a little bit for who makes some of the decision for technology adoption. It goes into hospitals and then sometimes insurance companies in terms of will we allow it through tech assessment and or will we pay for it? As you get even further and more established, then at times governmental agencies or public health policy can have an impact into much broader technology adoption. If we think about the different perspectives of at least the first three, providers, hospitals, and public health, each of us has a little bit of different expectations of what we're looking for new technology. I know when I think about adopting new technology, I think, can this improve the outcome of my patients? In particular, does it make things safer? Cryotherapy, I think, was one of the good reasons. Safety was a good reason for potential adoption a good number of years ago. So can we decrease complications? Can we have better outcomes? Are we more accurate? Does it make things faster? Do we have better decision-making and or confidence in that decision-making? Or is it more accessible, convenient, or ergonomic? All different things that make me have a smoother procedure and or hopefully which translates into better outcomes for my patients and or directly translates into better safety and or outcomes for the patients. The hospital has a slightly nuanced perspective. So they think a little bit more like, for the individual patient, is it clinically important when you weigh it against the cost? Safety is a very big factor in the adoption of technology. So safety, cost, and then also clinical value. So with clinical value, they will oftentimes think of how does the clinical value compare to what is currently done. So for example, let's use cryotherapy as an example. We have some value with a different technology that is a little bit safer, but we have to compare that to the more traditional radiofrequency energy when it considers cost and also things like safety and effectiveness. Also, they'll look at what are the implementation challenges. Does this take quite a bit of nursing education? Does this mean you have to take out the whole cath lab that's currently there and the infrastructure to support that? And then also, how does the technology position the providers and the hospitals in comparison to other hospitals and or providers? For example, if you happen to have a group who specializes in, let's say, dysautonomia, it might be very nice to have a high quality evaluation of the autonomic nervous system. That may be an expense that the hospital will then value. The government has a different perspective. Their perspective is for the population. Is it clinically important, weighted once again against cost, or in this case, it would be against budget? They also look at, do guidelines support its use? There are a number of technology assessment groups that healthcare HTAs, healthcare technology assessments, that can help assess what is the, on a population base, what is the best way to spend our resources. So cost in relation to budget with evaluation also of things like acceptability, feasibility, and equity. So a much broader perspective. This is a little bit further down the chain. So we're going to discuss a little bit more about how do we adopt new technologies. This is really driven by providers, hospitals, and industry. And so as we think about this, we need to speak the same language. Oftentimes, the hospitals and the providers, and to some extent industry, thinks about how effective is it, how much does it cost, and then what does the provider and or hospital need or desire. So let's look at this a little bit. The hospital assessment has kind of a nice scheme that's essentially something like this. Is the cost more? Well, you need more of a clinical advantage. If the cost to clinical advantage is appropriate, they will approve. If the cost to clinical advantage is not enough, then it would reject. So it's a very simple formula for how you might look at how the hospital is going to think about things. But here's a little bit more nuanced. A little more nuanced is looking at clinical advantage, safety advantage, and then also the financial analysis. And so if there's a clinical and or safety advantage and the financial analysis makes sense, then generally hospitals will recommend adoption. If there's no clinical advantage, no safety advantage, but the hospital analysis, the financial analysis makes sense, they'll defer. So not necessarily yes or no to the technology. However, it becomes a little bit more challenging if the financial targets are a bit more challenging. So if it does not make the particular target that was set, that can vary depending on the needs of the hospital. But if there's a clinical and a safety advantage and the financial analysis is not met, it may be adopted depending on the relative merits of either the clinical and safety advantage and the relative costs. And then, of course, this makes sense if we have no significant advantages from a financial or safety, and it does not meet financial analysis, then they will typically reject. So in a lot of these areas, there's a little bit of room for clinician impact in the new technology assessment. So as we think about what are the clinical advantages that hospitals are looking for. So oftentimes they're looking for things like effectiveness. Does it make you more accurate? Is it more successful? Is it more accessible? Does it help you avoid poor outcomes? Does it improve decision support? Does it improve ergonomics? Or does it help with high-risk patients? Safety is also a big issue. Is the new technology safe itself? Does it decrease complication risk? Does it help avoid poor outcomes? Is it efficient? Does it have lots of waste of supplies? Does it allow reallocation of other resources? And then also, is it timely? Does it reduce either the weight of the provider or reduce potentially harmful delays for the patient itself? So these are some of the main things that clinical advantages that the hospital looks at for when considering clinical advantages. If you think about the quantity of the advantage, though, that's relevant too. If you think of something like an AED, this has a huge advantage for a small number of patients when you get shocked out of a potentially life-threatening rhythm. If you think about some other technology, so for example, NIRS on our patients, NIRS will give oftentimes a very small amount of improvement in a large amount of patients, though I must admit at times you can have actually a very significant amount of improvement as you think about the advantage of NIRS, continuous real-time monitoring, over the challenges associated with getting mixed venous saturations. And so the quantity can be for a lot of people and or especially big for a few people, and that can both add up for potential significant advantages. So to support clinical advantages, there's research and things like that that can help you give additional weight for the scales. So there's also companies out there that do this. Lumira is a company that actually works on product and assisting hospitals with evaluating with new products, and they have a area that says support of the clinical advantage from research, related literature, and trials. And they say, well, we have level of evidence. Is it product specific or is it group specific? And then what is the level of evidence that helps support the use of this? And the lowest level of evidence would be things like a case report discussing its use. With the highest level of evidence, we get into blinded kind of studies that have significant impact, so controlled blinded studies. In addition, they look at things like guidelines, so guidelines for use of particular products that help support the clinical advantage in particular. Once again, we get back to the implication of cost. The implication of cost has, of course, the different differences. If you have a disposal product like NIRS patches, that's an example of the NIRS patches here, or something much bigger than like the stereotaxis here. And so you have to have a better clinical advantage for products that will cost more money. At the same time, we have to realize that products that are disposable continue to add up over time. So once again, there's an evaluation. That evaluation process needs to consider both disposables and also the large initial costs associated with it. So financial consideration, they really think, the hospitals oftentimes think about, what is the expense in comparison to the potential revenue or potential savings? And so expenses can, of course, be the cost of the technology. We may think with stereotaxis, the cost of setting up the cath lab and buying the system itself. And then we consider the cost of consumables. In this case, my last slide with NIRS patches. And also there's a cost of technology delivery. So for example, is there a particular education and or time that's required? For example, if you need an EKG from the hospital, there's an EKG tech that comes to do that. And the EKG tech is oftentimes more expensive than the EKG itself. So there's a cost of both use of resources and also consumables and the technology itself. On the flip side, we have potential revenue. So the revenue could be reimbursement for the tech itself. Can you charge insurance or charge the government? Will it get reimbursed? This is where oftentimes technology assessment and or governmental healthcare agencies can help technology move forward. Does the new technology allow procedural billing? So for example, if you have a procedure like an electrophysiology study that you can do now because you're using some of the technology of a irrigated tip catheter, you have to think, does that help bring revenue into the hospital? And then also, does it save money? Does it cost less than similar technology? Is it decreased length of stay, decreased complications, or allow reallocation of resource staff? All different weights for the scales to make a financial impact, either positive or negative, to assist with technology assessment. Then there's the additional criteria. So provider and or hospital reputation, and to some extent provider desire and or expertise. So we could think of something like, what about low radiation equipment, getting the EnSite system and allowing you to have radiation-free procedures? Does this improve referrals? Does it improve you in comparison to other hospitals or keep you up with other hospitals? And then also things like provider desire and or expertise. Do you need particular things to run an effective health program? That may justify the adoption of newer technology. One of the questions I think we should ask ourselves, though, too, and this is one of the things that we always, I think, have trouble with, is at what point should we adopt new technology? Our field is really driven by technology, and it's very easy to sit on our haunches and not adopt new technology. I remember having years ago conversations with people about adopting radiation-free procedures, and sometimes the conversation was something like, well, is 5 or 10 minutes of fluoro really bad or not? And I think we would all agree that we are moving towards radiation-free. And so ALARA, as low as reasonably possible, is now 0 in the majority of cases for a lot of us. And so we're moving that way. So when should we adopt new technology is something we should think about, and you can do, to some extent, do that evaluation with the same assessment that we make and our hospitals make. And so how do you get technology into your hospital? Well, first, you need to work closely with your hospital tech assessment team. You need to carefully communicate clinical advantage, provider and or hospital need and reputation, and also the costs and or revenue associated with that new technology. Especially earlier, you need an active clinical champion. Some hospitals actually, this is a little off the cuff, but it seems like this, almost have a policy of putting the technology to the side until you really fight for it. So it may not get approved, or it could sit there for a year or more before approval, depending on the interest in the physician itself. So early stage technologies, you definitely have to highlight the clinical need. You need a strong clinician champion, and you have to have a careful cost to benefit analysis. For more mature technology, oftentimes you can rely on supportive research, revenue data, and then also use at other centers. And that's it. So thank you for listening to the discussion about healthcare technology assessment and the implications for potentially adopting new technology at your hospital. Thank you.